Good morning. My name is Anna Chicura, and today I'll be presenting my research on the postoperative complications following lumpectomy and mastectomy in women with pregnancy-associated breast cancer. Pregnancy-associated breast cancer is defined as breast cancer that's diagnosed during pregnancy or within the first 12 months postpartum. It's the second most common malignancy in pregnancy and is diagnosed in approximately 1 in 3,000 women. Different treatment options for breast cancer include surgery, chemotherapy, radiation, endocrine therapy, and anti-HER2 therapy. For pregnancy-associated breast cancer, chemotherapy can safely be started in the second or third trimester. Radiation, endocrine therapy, and anti-HER2 therapy are contraindicated throughout pregnancy, as well as in the postpartum period if a woman's lactating. Surgery can be performed at any point in pregnancy, but is safest in the second or third trimester or postpartum. Classically, women are offered a modified radical mastectomy, but breast-conserving therapy can also be considered if radiation is deferred until the postpartum period. The incidence of surgical complications following partial mastectomy for pregnancy-associated breast cancer is poorly studied. The largest study reports on a total of 67 patients, 20 of whom underwent breast conservation therapy. The authors report a 9% complication rate, all of which occurred in patients who underwent mastectomy. They report 4 cases of cellulitis, 1 breast hematoma, and 1 axillary abscess. None of these patients required reoperation for their complications. One complication of particular interest, milk duct fistula, has been observed after breast biopsies, as well as from an abscess in the breast of a lactating woman, but has not been reported in patients with pregnancy-associated breast cancer treated with lumpectomy. Therefore, the primary aim of this study is to identify the incidence of complications following breast-conserving surgery and mastectomy for pregnancy-associated breast cancer. This is a retrospective study that looks at patients treated at the Cleveland Clinic between January 1st, 2000 and January 1st, 2020. In order to identify patients who were eligible for the study, we first looked at patients who had a pregnancy episode created in EPIC. We searched those patients both for the ICD codes for breast cancer as well as the CPT codes for relevant breast surgeries. For those that did not have a pregnancy episode, we searched the Cleveland Clinic Breast Cancer Patient Database for all patients who were diagnosed with breast cancer under the age of 50. From this database, we first searched for the CPT code for cesarean section, and then for the ICD codes for breast cancer. We then looked for the CPT codes for breast surgery, and then searched for the word pregnancy in the operative report. Finally, we searched for the ICD codes for pregnancy within this database. Patients were considered eligible for the study if they had a biopsy-proven malignancy during pregnancy or within 12 months postpartum. There were 21 patients who were diagnosed with pregnancy-associated breast cancer during pregnancy, and 34 patients who were diagnosed with pregnancy-associated breast cancer in the postpartum period. The majority of patients presented with a palpable mass, pain, or erythema. Other common presenting complaints included decreased milk production, a change in bra size, presumed abscess, and nipple retraction. Nearly half of patients presented with clinical stage 2 disease. There was no statistically significant difference in the clinical stage at presentation for patients who were diagnosed in pregnancy or postpartum. The majority of patients presented with infiltrating ductal carcinoma, followed by ductal carcinoma in situ, and invasive ductal and lobular carcinoma. Over 70% of patients presented with grade 3 disease. There was no difference in the histologic grade at presentation for patients who were diagnosed in pregnancy or postpartum. Likewise, there was no statistical difference in the presentation of patients with triple-negative breast cancer, hormone receptive positive disease, or HER2 positive disease. Focusing on patients who were diagnosed in pregnancy, the median gestational age at the time of diagnosis was 25.9 weeks. The median gestational age at the time of surgery was 33.7 weeks. And the median gestational age at delivery was 37.9 weeks, most commonly via vaginal delivery. In comparison, patients who were diagnosed postpartum were diagnosed on an average of 25.9 weeks postpartum. When comparing patients who were diagnosed in pregnancy and postpartum, there was no significant difference in the age at diagnosis, BMI, or medical comorbidities. The most commonly observed medical comorbidities included obesity, asthma, psychiatric illnesses, including anxiety and depression, or smoking. There was no difference in the rate of administration of neoadjuvant chemotherapy or the time to start of neoadjuvant chemotherapy for patients who were diagnosed in pregnancy or postpartum. There was no significant difference in the rate of partial mastectomy or total mastectomy performed in patients diagnosed during pregnancy or postpartum. Likewise, there was no significant difference in the rate of sentinel lymph node biopsy or axillary dissection for patients who were diagnosed in pregnancy or postpartum. There was no significant difference in the rate of immediate reconstruction. Of those patients who underwent immediate reconstruction, the majority had a tissue expander placed. Patients that were diagnosed postpartum were not statistically more likely to receive adjuvant radiation than those who were diagnosed in pregnancy. On postoperative pathology, the majority of patients were noted to have infiltrating ductal carcinoma in situ, and invasive ductal and lobular carcinoma. There was no significant difference in the pathologic stage at the time of surgery between patients who were diagnosed in pregnancy and postpartum. The majority of patients did not experience any postoperative complications, regardless of whether they underwent a partial or total mastectomy. Seroma was the most commonly observed complication after both partial and total mastectomy. 4 patients, all of whom had a mastectomy, required reoperation within 30 days of their initial procedure. The indications for reoperation included flap necrosis, removal of an infected tissue expander, surgical site washout, and recurrent chest wall mass in a patient with stage 4 disease. There were 2 readmissions during this period of time, both of whom were readmitted after reoperation. Of note, there were no milk duct fistulas observed. In conclusion, in patients diagnosed with pregnancy-associated breast cancer during pregnancy and postpartum, there was no difference in the rate of partial and total mastectomy, sentinel lymph node biopsy or axillary dissection, or in the rate of immediate reconstruction. The majority of patients did not experience any postoperative complications. The most commonly observed complication after both partial and total mastectomy was seroma, and no milk duct fistulas were observed. I'd like to thank my mentor, Dr. Zara El-Healy, my co-investigators, Dr. El-Sharif, Dr. Kalakanda and Meng, as well as John McMichael and Lynn May, as well as everyone in the Cleveland Clinic OBGYN residency.